Hello, everyone, and welcome to the Delirium interview, Impact of the COVID-19 Pandemic. My name is Amanda Vasquez, and today I'm joined by my colleagues in Senior Friendly, Jonathan Lowe, Belinda Wagner, and Deb Brown. Over the past few months, we have experienced unprecedented change in our hospitals. While the magnitude of the coronavirus surge thankfully has remained manageable within the limits of our healthcare system, we need to acknowledge the effects on patients of restrictions made to limit and prevent the spread of COVID-19. The development of delirium is always a concern with our older patients in the hospital, and there are reports of an increase in delirium cases in hospitals globally during the pandemic. We are fortunate today to have two excellent physicians join us to discuss delirium prevention management for our older patients who are living the pandemic hospital experience. Dr. Eric Wong is a clinical associate in geriatric medicine at St. Michael's Hospital and University Health Network. He attended medical school and internal medicine residency at McMaster University and completed geriatric medicine residency at the University of Toronto in 2018. He is enrolled in the Clinician Scientist Training Program at the University of Toronto as a PhD candidate in clinical epidemiology under the supervision of Dr. Sharon Strauss. And Dr. Robert Young-Collins is head of the medical psychiatry program at Sunnybrook Health Sciences Centre. He received his MD degree from the University of Toronto in 1981 and his FRCPC designation in psychiatry in 1987. He is an assistant professor at the University of Toronto, and he has been a staff physician at Sunnybrook since 1988. Today, our session will be moderated by Deb Brown. Deb has been with Sunnybrook since 1994, beginning her career here as a clinical nurse specialist. Currently, she occupies a corporate nurse practitioner position with the Senior Friendly strategy, and her clinical research interests are in delirium and senior-friendly hospitals. Take it away, Deb.
Thank you, Amanda, and I want to thank everybody for coming on board and participating in this wonderful event, and as a special hello to Eric and Rob. Thanks for coming on. So I'm just going to start and ask some questions, and we'll facilitate our dialogue from there. So Rob and Eric, when we think about this whole coronavirus, really, what worries you most about the virus and its impact on our elderly patients? What are your thoughts? Eric, do you want to start?
Sure, yeah, for sure. So thank you for inviting me for this talk. There are lots of things about the coronavirus situation that we're in that are concerning. But I think the biggest thing that I've seen is the lack of family and caregiver presence at the bedside. And this is by virtue of the virus, it's a requirement to prevent the spread. But at the same time, the older adults that we treat are vulnerable, and these caregivers and family members are essential to their care. So the isolation can sometimes lead to neglect, can sometimes lead to more challenging care for them. The other thing is that older adults may not be as able to adapt to virtual technology as younger adults. And we know that in our world, that the reason why the world seems to be adapting well is because there's a lot of digital technology, a lot of virtual technology, but we can't forget that the older adults that we treat may not be able to use and adapt as quickly as we are.
Right. Thank you, Eric. And I think, just as a comment, sometimes the technology can be a scary thing for some of our older patients. Rob, do you have any comment on that?
So, you know, I'll steal a line from Sharon Inouye. She had an interview in the Harvard Gazette a few months ago, and she didn't even talk about patients that had coronavirus. She said everybody else, all the elderly that are out there in the community are at risk because they're stuck, they're at home, they're more depressed. And I have two of my own patients, I can speak from experience, who now are in retirement homes and they're not allowed to get out the front door. Of course, the patients that I see, since I'm a psychiatrist, have psychiatric conditions as well. So their depression is worse, their sense of isolation is dramatically increased. And those are the folks that don't even have COVID, right?
Right.
So they're kind of the collateral damage. And then I obviously have my own patients as well that were infected with the virus. And maybe we'll talk later about what happened to them, because that's another whole difficulty in reemergence from delirium there as well. So I think it's hitting all of the elderly population.
Right, right, right. Okay, so some may think that the COVID crisis has created a new reality, a wake up in healthcare, and we should maybe triage delirium off the table as a priority. But of course, we know of significant rises being reported in delirium rates with the onset of COVID. And the pandemic itself, and as you've just spoken to, and the requirements of care in a pandemic lead to conditions almost perfectly designed to cause delirium, and certainly making the management of it challenging. So what have you both noticed in relation to the rates of delirium since the pandemic, and what changes have you witnessed in relation to our practice, our hospital practice with delirium prevention strategies? Rob, do you want to take the lead on this for now?
Oh boy, I think that's a complicated question, because obviously there's still patients in the hospital that are, I mean, the majority of patients obviously here are COVID negative, right? We have
Right.
2.5 wards that have COVID positive patients. So I'll use C5 for those who know Sunnybrook. Like the trauma ward that was here, there was actually a sharp decrease in occupancy in patients there. There were less bar fights, less car accidents initially.
Right.
So some of the places where we saw delirium actually went down. Elective surgeries, elective neurosurgeries down, elective orthopedic surgeries down. So there were many factors going on at once. I think some of the delirium that we normally saw kind of went away, just because the patients weren't there. I mean, obviously they're coming back now. We'll have a further discussion, I think, a bit later in the whirlwind, in the vortex of looking after COVID positive patients. Did we neglect our duty to kind of screen properly for delirium and other patients? And I think that might actually be the case. And obviously everybody knows that statistic. If you actually don't carefully look for delirium, you don't see it.
Right.
So you have to use validated tools, and you actually have to go out there and look for it. And there was a great quote that I saw in one of the papers that, since we're so worried about lungs, we kind of forgot about the brain.
Right.
And obviously, delirium has long-term ramifications that are just as bad as any other acute illness.
Right. And, my concern has been as well that, requirements of COVID care and isolation care is that staff need to get in and out very quickly. And that creates a problem when you have to really sort of try to understand if there's been some cognitive changes. Look specifically for signs and symptoms of hypoactive delirium, which take a little bit of time as well. And so we may be missing some of that. Eric, did you have any comments in relation to the rates, or what changes have you witnessed in relation to our practice with prevention strategies?
Yeah, actually, I agree with Rob. It's the same situation as St. Mike's. The overall hospital volumes are lower. So at St. Mike's, we also see trauma, we also see hip fractures, and we have quite a bit of elective and non-elective surgery. So it's lower in terms of the prevalence, just because the hospital volumes are lower. But they are happening, and when they do happen, it's difficult to manage. I think, as Rob talked about, some of the biggest changes is the lack of human contact. And I think delirium in itself is sort of, the way to treat it requires human contact. Like there's no other way of going at it. You can't give somebody a pet seal robot, that can only do so much, like a pet robot cat or a robot seal. But really what you need is somebody who knows the patient to provide the care that is not being provided. And most hospitals stop all the volunteer services. And we know a lot of the ways hospital prevents delirium is by volunteers using something like the HELP program that Sharon Inouye created, and sort of programs similar to that. But because there are no volunteers, sometimes the volunteers are actually the ones who are tracking some of these prevention strategies and maybe alerting care staff that something is wrong. And when there are no volunteers, when nobody's really allowed to go into the room, and as Deb, you said, you know, even the nursing staff, they have to think about what they're doing. They go in for a minimal amount of time and they come back quickly. They try to group test, care with the meals so that you don't have to go in, meals, and then afterward you go in for the meal and you provide some care. So there's definitely less opportunity to detect issues, and delirium fluctuates. So you really need to witness that to see it, frequently.
I agree, Eric, and it's challenging even when in normal times, because of the fluctuation of delirium and the change in the change of staff, etc. It's tough in the normal times. So now it's even more tough given the circumstances of that we're in. What about the ICU? We know that delirium rates in the ICU are amongst the highest, and with the sickest patients in there. Is there anything we can do to sort of, I guess, reduce the limit and the burden of delirium on patients with modifiable risk factors in this environment? And what have you seen happening? Rob, do you want to start?
I have to think about that. I mean, critical care in Sunnybrook, that's a wonderful, wonderful team. And they, they're very attuned to delirium. I don't know if they're doing anything any differently because of their COVID patients. Again, I think the last time I looked at critical care, the burden of patients was not all that high. So I think it still allowed them to do their usual good work. I think in other hospitals, obviously when you look at the pictures and the videos coming out of the States, when you're totally swamped, then you're giving medications you shouldn't give, you're not taking histories, you're just running around. So I think critical care at Sunnybrook at least has done a very good job. So I think like 99% of my answer would be to continue doing that. I mean, obviously for delirium, they always look for modifiable risk factors. They're always mindful of medications that make things worse, not better. And again, remember, we used to teach our residents years ago that, for example, like low-dose antipsychotics might be neuroprotective. They might actually help your brain. There were rat studies like that, right? And the evidence now is that's just not true. So taking away culprit medications is an important thing. They do that very well. I still think they screen for delirium very well there.
Okay. Eric, do you have any comments in relation to your practice or St. Mike's?
No, and I agree with Rob. Actually, I was seeing the same thing. There's been a lot of effort and collaboration by the geriatric groups at St. Mike's as well to work with the ICU team to sort of learn their needs and figure out how we can help prevent delirium and treat delirium in the ICU. I think most of the time in the ICU, people have delirium because of underlying issues that are really non-modifiable. They're critically ill. They have a lot of restraints and access, including intubation, ventilators, and IVs and lines that, it's hard to modify those kind of triggers. But I agree with Rob that medication is probably the primary issue. The thing that I see a lot is undertreatment of pain in certain scenarios. And I think, both Sunnybrook and St. Mike's, there's a big surgical service, and, post-operatively in the ICU, sometimes there's a hesitancy to give opioid medications in post-operative patients for the concern that they are in delirium or they're going to go into delirium. And, from a geriatric perspective, we think that pain itself is a trigger. So, we don't want to not treat people's pain or undertreat the pain. And, but you do see, I still see it here and again, using antipsychotics instead of adequate analgesia to treat agitation in the ICU, and that is concerning. But I think, this is not just worse with COVID. This is something that's been going on for some time. We've worked with education projects and role modeling to try to correct that. And I think overall things are actually getting quite a bit better. I agree with Rob, things at St. Mike's, the ICUs that we work with, and particularly the trauma ICU, we've seen a very good improvement. They'll reach out to us. We actually go in and we do consults in the ICU for some of these geriatric trauma patients, and we're able to help with their care.
Right. Okay. Very good. Now, we talked about the absence and the impact of the absence of family members, in their inability to visit their loved ones, even with or without delirium. Have you had any feedback from families that you may have been in touch with, either of you, in relation to how they're feeling during this time? What's the biggest frustration? What are their fears? Rob, you have any comments?
So absolutely. Somebody they just saw, so I have an 85-year-old woman who's only Farsi speaking up on the floor right now. And she had come in and she looked agitated, and she wasn't eating and she wasn't drinking. And her daughter was just in tears that a week, 2 weeks before she'd actually been quite good. And this was a sudden change. And it was only, they allowed the daughter, and she was pleading to get into the hospital. They let her in for an hour and we did the interview together, and it became immediately clear that she said, well, it's because the food has been poisoned and all my family in Iran have been killed, right? And so this whole story emerged just because we could get the family member in there. And I won't tell you the treatment after that. She looks way better now, but our family response is that it went up through layers of bureaucracy, and they allowed her to come in for 1 hour at lunchtime every day so she could feed her mother, and so I could do a translated interview. And so before she was able to come in, and she's a lucky woman, right, that she was given the permission to come in, but she was absolutely in tears that she said, my mother is dying, she's not eating, there's nothing I can do about it. So in that one case, we had a very good outcome because the hospital kind of not bent the rules, but made a decision to allow her in for kind of like a diagnostic and treatment modality.
Right. Very good. Eric, any comments?
Yeah, no, that's a great story to hear from Rob. Yeah, I think it is really, up to hospital management to sort of allow exceptions. We try to advocate for this at St. Mike's. It makes such a big difference to have the family there, especially in some cases where they're in delirium, but their goals of care are sort of palliative. The hospital guidelines say like you have to be imminently dying, even if you're palliative, you can't have family. And there's an element of cruelty to that, I think. Not letting patients who are in delirium to be with their family. The family members that I've been in touch with, they are understanding. Like, they know that the situation is exceptional and that we're trying to do the best we can. We have some success with iPads. So
with what? Sorry, Eric?
With iPads, we have some success with using iPads and bringing that to the bedside. But of course, some of the family members may not have access to the technology themselves. I think there's actually still people out there who may not have internet or may not have a device that has a webcam that allows them to use the FaceTime or Zoom technology. But where that's possible, we do have a few iPads in the geriatric program at St. Mike's, and we're trying this out with patients.
Right. Very good. So I want to talk a little bit about antipsychotics and sedatives, and we all know that avoiding the use of sedatives and antipsychotics, if possible, is an important practice in delirium prevention and treatment. However, during these times when social distancing and isolation procedures are requirements, an increase in the use of these medications certainly may be necessary at times, as the potential for harm to others can be significant. How do you both feel about this? What has been your experience? And what are your sort of ethical principles that you review in your head when you're making decisions about medications and antipsychotics during these times? Rob, do you want to start?
I mean, I'll quote Sharon Inouye again. And one of her things, she said that, you know, that the COVID pandemic has kind of been the perfect storm to set back kind of teaching and treatment of delirium, because now since there's this kind of vortex of anxiety, people are jumping in and jumping everywhere and giving medications. I mean, she would still be the first to say that the evidence is not that they're bad boys and not good boys, right? That we should still stay away from jumping to pharmacological management. And I mean, obviously, her whole life, her whole research has been geared toward what are the multi-component non-pharmacological things somebody can do to decrease the severity and duration of delirium. Having said that, I mean, but we do teach our residents, sometimes if somebody is incredibly agitated or incredibly psychotic, I mean, that's still judiciously and with a lot of thought, a road that will go down. I think the evidence is pretty clear that there's some, you know, giving benzodiazepines, I think just about everybody would agree, and there's clearly good studies for that, that they make delirium worse. Unless you're catatonic, unless you're in alcohol or benzodiazepine withdrawal, just kind of giving somebody midazolam or lorazepam, you shouldn't be doing. Do we at times, focusing very much on target symptoms, give antipsychotics? We do. I must say we do. I mean, years ago we gave a lot more, right? That we kind of think that, again, that antipsychotics might put your thinking back in a straight line. So we'll just give you some low dose Haldol. And I think that thinking really is reduced now. So on a case by case basis, we try to figure out what's the exact symptom we're trying to hit. And realizing that our antipsychotics, yeah, too, they have their own whole set of side effects to them.
Yeah, right. Eric, any thoughts you'd like to contribute?
Yeah, no, I agree with Rob exactly about the use of antipsychotics and about that thought about, like, you know, rolling back, you know, what Sharon Inouye said, you know, the progress we've made with delirium treatment and prevention. You know, I've seen, you know, on Twitter, different experts sort of advocating for different things, but I think in general, people realize that, you know, if somebody has delirium and they're mobile, so they're able to walk and to wander, that poses an imminent risk to not only themselves, because they may be COVID negative and they can be exposed, but also to the care staff if they are COVID positive and they start, you know, wandering outside of their rooms. As far as I know, the hospital rooms are not actually locked, right? The rooms are isolated, they're negative pressure, but they're not locked. It can't be locked for fire safety reasons. And so, you know, I've seen actually a patient come out of their room, and, you know, we're passing by and we're wondering, like, is this patient infected? Do they need to be inside? And sometimes the nursing staff isn't right there to say, you know, go back into your room. And so, you know, I think there are situations in this COVID era where instead of using physical restraints, which I've also seen during this time, you know, somebody with COVID in physical restraints, again, you know, a very, you know, not ideal at all. It causes a lot of harm to patients, increases agitation. We know all of this. So sometimes as almost like a harm reduction measure, we use antipsychotics in this situation. Try to use the lowest dose as possible, think about symptoms that could be addressed, think about the underlying triggers and stuff that we can look for and correct. So, you know, and again, a lot of this stuff requires patient contact, right? Like dressing constipation, examining their abdomen, or doing an x-ray, or looking at their bladders to make sure they're not retaining urine, or blood work and stuff like that. So, you know, we do try to, you know, coordinate, go after the underlying causes, but sometimes if risk mitigation is needed, you know, you really don't have much choice. And I agree, like the evidence for antipsychotics, as more and more trials and systematic reviews come out, they all have one message, that they don't really work. And so, you know, sometimes you're limited in your toolkit, but if the need comes and you have to use something, you just have to use something to manage the crisis.
Right. Very well spoken, Eric. And I think you bring up the concept of wandering, which can be very challenging and can be difficult for the staff to be able to manage. And you know, there are some environmental things we can do, like stop signs and barriers that you can put on the floor that remind or serve as a reminder to try to stop and not go through. So there are some environmental things we can do, but wandering is challenging at times. So so it's something that we really have to try to put a lot of effort into. And again, we don't have our families there as well with our patients to help redirect. But again, it's getting back to this understanding root cause for a lot of this. You have to spend some time, and you have to spend some time digging in. Sometimes we don't have the time for that. So, okay, very good. And the other thing I wanted to just sort of, probably the last piece I wanted to touch base on is communicating, because I think we have a long way to go with being better at communicating generally with patients who are elderly and maybe having some hearing deficits, but in the presence of delirium as well, communicating verbally and non-verbally with a pandemic requirements for PPE is difficult. And I say especially challenging for patients with delirium. What are some of the strategies you've seen to address this? Have you seen anything, or can you recommend anything that can help with the communication piece? Because when you have the PPE, and so much of what our presence with the patient is nonverbal and a bit of verbal as well. Any suggestions? Rob?
So sure, I mean, there's all kinds of ideas out there. The regional geriatric program, as you know, has a kind of a web page that addresses exactly that. I mean, first of all, it goes over the difficulties that if you're, sometimes communication is difficult with patients just right out of the box. But if you've got a face shield and a mask on, it's just makes it so very difficult. So if you go to the RGP page, you'll see that they say smile, because even if you've got a mask, you'll see it in your eyes. You'll see, and that, you know, like touching a patient is okay, and giving your name is okay.
Right.
You know, and I'm here to do this.
Right.
And so giving clear information in a clear voice, in an empathic voice. On our ward here too, we have the laminated, you know, photo, you know, this is what I look like, which is a good thing to do. So, I mean, I think everything that we know to speak with our patients, our elderly patients and delirious patients, but just amped up a whole, that just amped up even more, that we have to be thoughtful about how difficult it is.
Right, right. Eric?
Yeah, no, and I agree with Rob's thoughts on that. It is very challenging, and I think it's just by nature of the type of PPE we need. There's really little way of getting around that. I like the picture approach. Like I like, you know, putting a face to, you know, to who you are behind the mask. I think that's important. It's also hard to speak clearly. I think when you're wearing a mask and you have a face shield on, you have like two things in the way, and you're trying to, like, you know, some people are hard of hearing, and you're trying to really let them hear. The good thing is, you know, at some hospitals, I know at St. Mike's, they've opened up all the phone lines. So, you know, patients can use the telephone inside their rooms for free. And, you know, you can call in. Sometimes it may be easier for them to hear out of one ear if you can call them and do part of the interview by phone. Of course, this is very challenging with people in delirium. They may not be able to, they may have apraxia or not be able to operate a telephone properly. But you know, there's some strategies of getting around that. But I think in general, it is, you know, it is challenging because it's a barrier that's hard to resolve.
Have either of you seen any of the masks that have a clear piece where your mouth is?
I have not.
Okay.
I've seen it on the internet. I don't know if those are approved by IPAC.
Okay, very good. But as you say, Rob, thank you for that comment and the referral to the RGP website. There's a plethora of strategies on how to communicate, how to approach, make sure the patient can hear you, can attend to you using simple, clear language, taking your time, asking permission, using touch appropriately, etc. So the RGP website is an excellent source for delirium care. So that's about it for my questions for you two. I just want to ask you in closing, do either of you have any words of wisdom or support or final thoughts that you'd like to leave with us as your message about an expert in delirium care? Rob, any parting messages you'd like to leave?
I mean, there could be all. I'll tell you though, the personal one for me is the patients, the elderly patients that I've had that have come out of their, and one was intubated for weeks and weeks, that have come out. Again, this is, you know, any body inflammation here is a brain inflammation here. So delirium is a neuroinflammation anyway. But you know, there's evidence that this virus actually does get into your brain, right? It goes up into your olfactory tract, and they can see it in there. They can test for it in there. And it's, some of my patients now have a curious kind of prolonged neurocognitive impairment that I'm going to have to keep an eye on. And I think, you know, it affects all parts of your body. And I just wonder if this, for some of my patients, hasn't been a bit of a neurocognitive hit. And I mean, obviously the evidence is that if you get it, some folks go through a very long kind of convalescence to get out of this. So right. I'm going to be keeping my eyes open.
Okay, very good, very good. Eric?
Yeah, no, and I like Rob's thought, because there have been some neurologic studies, and I think in France, and there was an article in the New York Times, obviously, that's more anecdotal. But there does seem to be neurologic consequences from COVID. It's unclear whether it's an encephalitis, like whether it's actually, you know, causing an encephalitis picture, or whether it, like as Rob said, it's you know, subtle sort of subcortical cognitive deficits that will take time to resolve. But you know, nobody really knows, because part of it is the sicker the patients are, the more likely that they would have been exposed to critical care and all the interventions of critical care. And so that, you know, we know that ICU delirium tends to have consequences. People's cognition tends to linger. You know, we've seen that in the surgical population with the post-operative cognitive decline. And then some of them transition to a major neurocognitive disorder or dementia. I think, you know, one thing we should, as a systems approach, think about is, as we are reopening, as we are resuming medical care, not to forget where we started, right? We started with some very good delirium prevention strategies and a very good sort of systems approach, top down, from, you know, volunteers, from educating the care staff, from having family involvement. You know, we have a good program here, and a lot of this is with thanks to the RGP, who have advocated for these resources. And, you know, as we're reopening, we should really think about it and start to prioritize the things that have worked for us in the past and start to bring them back, instead of waiting for that to be the last thing on the agenda, right? Like, resume everything else first, and then bring the geriatric delirium prevention stuff back after the surgeries are allowed to continue. So, you know, we really need to time resuming of these delirium prevention care strategies along with the reopening, so that we can provide the supportive care that's needed as people go back to surgeries, and as people go out, and as our trauma units and our surgical units get more busy.
Very well said, and a great point, and you're absolutely right, Eric. Timing is everything, and we should be more, we need to continue to be proactive, that when we open up our surgeries and our beds more, we're right there with our delirium prevention strategies. So that's it. That ends the questions at this point in time. I want to thank both of you very much for your time and your expertise, but I'll also, before you leave, ask if our panel members have any questions that you would like to ask Rob or Eric.
So as a physiotherapist, pain management is a really big part of my focus before mobilizing patients. And in the emergency department where I work, my focus is on keeping seniors up and moving, which also helps with their delirium as well. Eric, you were saying that pain that's not managed is a big contributing factor to delirium, but in my experience, too much pain medication makes them too foggy and drowsy as well. So how do you balance that and advocate for other types of management to make sure that your patients aren't in too much pain so that they don't get delirium, they're able to move and do other things that help them move forward with getting better?
That's a great question, and you know, it's a challenge that, you know, every time I'm on service, and I'm going to go back on service in 2 days, we see that, and it's always a struggle. I think that why pain management is difficult is because you have to tailor it to each patient. You know, it's hard to have, you know, for example, heart attacks, acute coronary syndrome. You have a cocktail. And it's the same cocktail for everybody. Really, it's the same things, right? It's an aspirin, you know, put some antiplatelet therapy, some ACE inhibitor, and it's the same thing. You just give it all. In pain management, it's harder because of all the nuances, right? If you give too much opioids, yeah, you're going to have sedation, you're going to have constipation, you're going to have delirium and confusion. But if you don't do that, then you're going to have issues. And so, you know, from a geriatric perspective, we often resort to, you know, acetaminophen. We think that's a safe medication to use as long as you use it within the dose range, usually less than 4 grams, less than 3 grams in a total daily dose. We think that's a good, you know, first step for all pain management. Like for certain exceptions, you know, if they're heavy alcoholic or if they have like cirrhosis, then maybe like lower the dose a little bit. And then there's some adjuncts. Now, in the older population, you know, NSAIDs are also hard because there are side effects along with that, you know, GI bleeds, heart attack, renal failure, drug interactions with ACE inhibitors or ARBs. So that's also challenging. In certain people, if they don't have, you know, renal failure, if you're using short courses, sometimes celecoxib or a COX-2 inhibitor may be helpful, but you have to monitor them, make sure they're not at high risk of cardiovascular disease. But I also like, you know, the adjunct modalities, right? That sometimes you're able to do non-pharmacologically. So physiotherapy is very important. You know, in a setting outside of COVID, maybe you think about stuff like, you know, acupuncture and other sort of, there's other like ultrasound or other modalities that people use. Some of it has better evidence than other things, but certainly, you know, pain management is a multimodal approach, pharmacologic and non-pharmacologic to get the ideal result.
Okay, very good.
Thank you.
Any other questions?
Rob, as you were giving the example of the Farsi patient a while ago, I'm just wondering, for those family members who are coping with having a loved one who's experiencing delirium, what kind of message or tip would you give them knowing that they can't always be present with them?
Well, I mean, I think first we have to, we try to show them, and sorry, my chair is very squeaky. We try to show them and prove to them that we're looking after their loved one very well. I mean, I think part of it is we have to show our caring and our empathy. I mean, for that patient, but for all patients, we educate them on what this is. It's quite frightening to see, in this case, her mother go from actually very high functioning to really outright psychotic, and what the animal of delirium is, and how we treat that, and what we do for that, and what we'll do in the future. So, I mean, a lot of it is very genuine hand-holding. A lot of it is education. I don't know if we can do any more than that. I mean, but that's what we should be doing for all of our patients, right? That we should be treating patients and families empathically, and we should be educating them about what we're doing.
Thank you.
I just have a thought. I mean, I'm not sure if you have given this a lot of thought. I know you work a lot in the hospital setting, but we talked a little bit about how the social isolation happens to our older adults, not just in the hospital, because of how we're quarantining. It's happening to all our older adults in the community as well. I was wondering if you've heard of any creative ideas that people have been implementing to stave off that social isolation in the communities, or maybe something we should be thinking about if, God forbid, there's like a second wave of this and we're experiencing the same kind of restrictions for either of you.
Do you want to handle that one first, Eric, or do you?
Sure. Yeah, I mean, you know, on Twitter and online, you see all sorts of creative ways people sort of like keep a barrier between themselves and are still able to be there through a window. Sometimes, you know, people be with their family members. Yeah, I think that's challenging, and it's an area of research that I think would be very helpful. I think there was you know, there's lots of observational studies from around the world sort of thinking about exactly what distance you need to keep. So there was a recent one in the Lancet commissioned by the WHO, done by a group at McMaster, showing that, you know, more than a meter is at least what you want, but then 2 meters is ideal. So I think once we sort of learn a little bit more about like the types of protection and the types of distancing we need, we can then have a more nuanced approach to you know, distancing between people, because I think this thing about, you know, the absolute distancing, right? You know, keeping older adults in their home, you know, locked away, do not visit them, you know, don't go near them, just leave the groceries outside. I'm not sure that's a sustainable approach, and I think as a society, like, you know, you see that there are some people in some groups who, you know, after a period of that are frustrated, and then they, you know, are not able to continue that for whatever reasons. So I think we actually need to do a little bit of research and figure out some sustainable approaches to doing it. We cannot just rely on virtual technology. I think that when I care for some of these patients in the clinic setting, outpatient setting, I tell people that caregivers, you know, if you have an older adult at home alone, they have early or mild dementia, and you're supporting them by the family, you know, visiting them often. But caregivers are not sort of an optional service. You know, caregiving is an essential service. You know, these patients who are at home isolated, they can't survive if there are no caregivers. They will have issues, they'll have complications, they'll suffer from neglect. And so I think from a systems perspective, there's a lot of good advocacy going on. I think the RGP is doing some, as well as a lot of the geriatric psychiatry, geriatric medicine folks in Ontario. But you know, we need to advocate and sort of say that, you know, caregiving is an essential service. So how can we make sure that people can do caregiving in a safe manner that is safe for the patient, but also safe for the caregiver?
You know,
yeah.
I'll just add, Carol Cohen, who runs our community team, always says too that, you know, even if you just have that one person that calls in on you, that's a life-saving thing. I must say I have a couple of patients that I kind of see virtually now, and their biggest complaint is nobody calls me at all. Like, I have a niece or a whatever, and they're just totally isolated. So it's really quite frightening. So actually, some of the folks that I see infrequently, I'm now virtually seeing more frequently, only because sometimes I'm the only person that's giving them a call.
Do you think that with this increased isolation of seniors at home, that we're going to see an increase in admissions in hospital because they're not getting the care medically, socially, functionally that they need moving forward?
I mean, Eric might be a better expert. I might leave it to him. But, you know, even with just when you read the New York Times and any other newspaper, where have all the patients gone? Like, who is not coming to the hospital? Who's not coming in, but they had a stroke or chest pain? And so the whole dynamic of who's coming in, I think, is interestingly whirling around at the moment.
Yeah, no, I'm
frightening a little bit, actually.
Yeah, absolutely. I agree with that. I thought there was a study showing that there was an increased rate of cardiac arrest or death from cardiac deaths during this time period. Of course, not a controlled series, but just an observational series. So yeah, no, I think that we will. You know, there are consequences to not having the preventative care, to not seeking medical attention in a timely manner. But I think we'll just have to wait and see exactly what the consequences are.
Very good. Well, I guess that wraps up our session, and I want to thank you both again for your wonderful dialogue, your insight, your caring, your compassion to all the patients and family members that you've been in touch with, and your care and support for us as well. So thank you very much.
You're very welcome.
Thank you.
To those watching, a question submission section can be found below this video on the Senior Friendly Intranet page if you have any follow-up questions for our guests today. We hope you found this video enlightening, and thanks for watching.